You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about localizing the origin of ventricular tachycardia and premature ventricular contractions. This is, I think, one of the most interesting topics in cardiology. Also, definitely not straightforward at all. Let's jump right in. The most common type of idiopathic VT is outflow tract VT. 70% of idiopathic VT is outflow tract VT, actually. And among outflow tract VT, the majority, 75%, originates from the RV outflow tract, and that accounts for 60% of all idiopathic VTs. RVOT ablations have a 97% acute procedural success rate with a less than 1% rate of procedural complications. The minority of outflow tract VT, 25%, originates from the LV outflow tract, accounting for 10% of all idiopathic VTs. LVOT ablations have a 94% acute procedural success rate with a 5% rate of procedural complications. The most common complication is pericardial effusion in 40%, followed by vascular access complications in 8% and injury to coronary arteries in 5%. Among LVOT VT, the most common site of origin is the aortic root at the right and left sinus or left aortic sinuses of Valsalva, or the commissure between the two sinuses. That accounts for 70% of LVOT VT, followed by the LV summit, which is 12% of LVOT VT, followed by the LV ostium, 5 to 10%, which consists of the aortomitral continuity, septal perihischian area, and mitral annulus. The takeaway from this part so far is that the majority of idiopathic VT, 70%, is outflow tract VT, and both RV outflow tract and LV outflow tract VT is very ablatable with a very high success rate in the mid-90s. Apart from outflow tract VT, idiopathic VT can also arise from the left anterior or posterior fascicle. 10 to 15% of idiopathic VT arises from the left anterior or posterior fascicle. This is the verapamil-sensitive one. It can also arise from Purkinje fibers, which accounts for less than 1% of idiopathic VT. This is the propranolol-sensitive one. Papillary muscles, which is 2 to 5% of idiopathic VT, and moderator band, which is 2.5% of idiopathic VT. Tricuspid annulus, 8% of idiopathic VT. Mitral annulus, 5% of idiopathic VT, or from the epicardium, which makes up 2 to 9% of idiopathic VT. Categorized by the side of the heart, non-outflow tract causes of RV VT include those arising from the tricuspid annulus, papillary muscles, moderator band, and crux. Non-outflow tract causes of LV VT include those arising from the mitral annulus, left posterior or anterior fascicle, and papillary muscles. This episode will not cover non-idiopathic causes of VT, such as scar-mediated VT from prior coronary artery disease. Throughout this episode, the term ventricular arrhythmia, or VA, will be used to encompass both VTAC or PVCs, ventricular tachycardia or premature ventricular contractions. Here are some key principles. Ventricular arrhythmias coming from the outflow tracts above atrioventricular valves, superior to inferior, will have a positive QRS in leads 2, 3, and AVF. In contrast, ventricular arrhythmias coming from the inferior ventricles below the atrioventricular valves, inferior to superior, will have a negative QRS in 2, 3, and AVF. Ventricular arrhythmias coming from the left of chest midline will have a negative QRS in 1. Ventricular arrhythmias coming from the right of the chest midline, in contrast, will have a positive QRS in 1. Most left ventricular structures are left of midline. As for the RVOT free wall is left of midline, so it will have a negative QRS in lead 1, but the RVOT septum is on the midline, and the right coronary cusp is right of the midline, so it will have a positive QRS in lead 1. Ventricular arrhythmias coming from the left ventricular free wall will have a right bundle branch block configuration, while ventricular arrhythmias coming from the right ventricle or the interventricular septum will have a left bundle branch block configuration. Therefore, a mitral annular ventricular arrhythmia will have a right bundle branch block configuration, while RV outflow tract free wall ventricular arrhythmia will have a left bundle branch block configuration. The precordial transition occurs progressively earlier, and so does the transition from left bundle branch block to right bundle branch block as we move from the RVOT free wall to the mitral annulus. Ventricular arrhythmias coming from basal and posterior sites will have positive precordial concordance, while ventricular arrhythmias coming from apical and anterior sites will have negative precordial concordance. The QRS transition varies with shifts in exit along a superior inferior axis and also a right to left axis. Ventricular arrhythmias coming from the septum will have narrower QRS complexes than ventricular arrhythmias coming from the free wall, consistent with synchronous rather than sequential ventricular activation. Ventricular arrhythmias coming from the epicardium in non ischemic cardiomyopathy will have a slurred, delayed upstroke of the QRS. These are the key principles to know when localizing VT and PVCs. There are some things that just can't be explained in audio format. For a more in depth treatment of this topic with visual anatomic examples, please visit my YouTube channel. Next, how does knowing the VT and PVC site of origin affect management other than eventual ablation? Well, RV outflow tract VTAC can be treated with beta blockers, calcium channel blockers, type 1C antiarrhythmics, or catheter ablation. In contrast, mexiletine, which is a class 1B antiarrhythmic, is used for reentrant or scar mediated ventricular arrhythmias and has no effect on RV outflow tract VT. VT with a right bundle branch block appearance and superior axis in a young person with no structural heart disease suggests idiopathic LVVT, likely fascicular, which is a reentrant tachycardia involving the left posterior fascicle, usually instead of anterior, giving a right bundle branch block like appearance and superior axis. Idiopathic left ventricular fascicular VT is highly sensitive to verapamil. It is a low risk tachycardia and can be completely cured by catheter ablation of the left posterior fascicle. VT with a left bundle appearance and inferior axis suggests right ventricular outflow tract VT, which can be seen in structurally normal hearts and has a benign course that is responsive to catheter ablation. However, you need to get a resting ECG to see if there are T wave inversions in the anterior precordial leads, which would be concerning for ARVC, in which case you need to get a cardiac MRI. What do the guidelines say about VT from specific sites? According to the 2017 AHA-ACC-HRS guideline for management of ventricular arrhythmias and the prevention of sudden cardiac death, for outflow tract VT in patients with symptomatic outflow tract VA in an otherwise normal heart for whom antiarrhythmic medications are ineffective, not tolerated, or not the patient's preference, catheter ablation can be useful. Class 1. In patients with symptomatic outflow tract VT in an otherwise normal heart, a beta blocker or calcium channel blocker is useful. Class 1. For papillary muscle VTAC, they say in patients with symptomatic ventricular arrhythmia arising from the papillary muscles for whom antiarrhythmic medications are ineffective, not tolerated, or not the patient's preference, catheter ablation is useful. That's a class 1 recommendation. Next, for idiopathic polymorphic VT or VFib, in patients who are young, less than 40 years of age, with unexplained sudden cardiac arrest, unexplained near drowning, or recurrent exertional syncope who do not have ischemic or other structural heart disease, further evaluation for genetic arrhythmia syndromes is recommended. That's a class 1 recommendation. In patients resuscitated from sudden cardiac arrest due to idiopathic polymorphic VT or VF, and ICD is recommended if meaningful survival is greater than 1 year. Class 1. For patients with recurrent episodes of idiopathic VFib initiated by PVCs with a consistent QRS morphology, catheter ablation is useful. Class 1. For intervesicular VT, the guidelines say in patients with verapamil-sensitive idiopathic LV VT related to the intervesicular reentry for whom antiarrhythmics are ineffective, not tolerated, or not the patient's preference, catheter ablation is useful. Class 1. In patients with sustained hemodynamically tolerated verapamil-sensitive idiopathic LVT related to intervesicular reentry, intravenous verapamil is recommended for VT termination. That's a class 1 recommendation. In patients with recurrent verapamil-sensitive idiopathic LVT, chronic therapy with oral verapamil can be useful. That's a class 2A recommendation. So that is a summary of what we need to know for localizing the origin of VT and PVCs. And again, if you're interested in more granular specifics, you can check out my handout or YouTube channel. PVCs. I want to talk about PVCs independent of localizing the origin of PVCs, since it's important to know, and PVCs come out all the time, every day on telemetry. In the absence of heart failure or coronary artery disease, isolated PVCs have no impact on survival. But in the presence of MI, PVCs identify patients who are at increased risk for VTAC or sudden cardiac death. Not all PVCs are benign. If a PVC occurs right on the T of the EKG, it is bad. It is a short coupled PVC, which is usually from the His-Purkinje system. It's going to lead to torsades someday. In the CAS trial, the cardiac arrhythmia suppression trial, use of class 1C arrhythmics such as flecainide or encainide to suppress asymptomatic ventricular arrhythmias after MI actually increased the rate of death, so flecainide can no longer be used in patients with CAD. The frequency of PVCs increases over the first several weeks after MI and decreases about 6 months after MI. Indications for suppression of PVCs are significant symptoms, sustained VT, or PVC-induced cardiomyopathy. PVC ablation can be considered if the PVC burden exceeds 15%. Catheter ablation is effective in 60 to 90% of idiopathic PVCs or VT, depending on the site of origin. Ablation of RV outflow tract PVCs has the highest success rate at 90%. Please remember that if the VTAC or PVC has a left bundle inferior axis morphology, it is a right ventricular outflow tract VT or PVC, which is the more common one. If the VT or PVC has right bundle superior axis morphology, then it is a left ventricular outflow tract VT or PVC, which is the less common one. When you see RV outflow tract origin VT, you must think either idiopathic RVOT VT or ARVC, arrhythmogenic right ventricular cardiomyopathy. What does the 2017 AHA-ACC HRS guideline for management of patients with ventricular arrhythmias and prevention of sudden cardiac death say about PVC-induced cardiomyopathy? For patients who require arrhythmia suppression for symptoms or declining ventricular function suspected to be due to frequent PVCs, generally more than 15% of beats and predominantly one morphology, and for whom antiarrhythmic medications are ineffective, not tolerated, or not the patient's preference, catheter ablation is useful. That's a class 1 indication. In patients with PVC-induced cardiomyopathy, pharmacologic treatments such as with a beta blocker or amiodarone is reasonable to reduce recurrent arrhythmias and improve symptoms and LV function. Class 2A. Can athletes with PVCs participate in competitive sports? According to the AHA-ACC 2015 scientific statement on eligibility and disqualification recommendations for competitive athletes with cardiovascular abnormalities, athletes with single PVCs and complex forms no greater than couplets at rest and during exercise testing without structural heart disease can participate in all competitive sports. The exercise testing protocol should be based on maximal performance rather than achieving 80 to 100% of the target heart rate to come as close as possible to the level of exertion achieved during their competitive sports, which is usually higher than the 85% target heart rate. Class 1 recommendation. Athletes with the PVCs at rest that increase in frequency during exercise or exercise testing and convert to repetitive form should have further evaluation by appropriate imaging or monitoring strategies before clearance for participation in high-intensity sports. If uncontrollable exercise-induced arrhythmias produce symptoms or lightheadedness or near syncope, fatigue, or dyspnea, the athlete should be limited to competitive sports below the level at which market frequency increase or symptoms evolve during testing. Class 1. Athletes with defined structural heart disease who are considered high risk based on the specific heart disease and who have PVCs with or without treatment should be limited to low-intensity Class 1A competitive sports. This statement applies whether or not PVCs in the setting are suppressed by drug therapy. Class 1. Some degree of risk can still be present during Class 1A sports, however, depending on the nature of the heart disease. Ablation of PVCs may be considered in symptomatic patients with frequent PVCs resistant to medical therapy. That's Class 2B. We should also know about Ashman phenomenon. What is Ashman phenomenon? It is intermittent right bundle branch block during AFib and aberrant ventricular conduction due to a change in the heart rate or QRS cycle duration. Whenever a long cycle is followed by a short cycle, for example, an AFib, the beat of the short cycle often has a right bundle branch block morphology with an RSR prime bunny ear in lead V1 because the impulse is blocked in a right bundle branch. The wide complex aberrant beat following the long cycle is an Ashman beat. It is often mistaken for a PVC, which is why I'm including it in the PVC section of the podcast. This is because the longer RR interval has a longer action potential duration and longer refractory period. When a supraventricular impulse reaches the His-Purkinje system while one of the branches, usually the right branch, is still in the absolute or refractory period, after the left side fires normally, the impulse eventually goes to the right side to fire in a delayed manner. It is wide because it relies on cell-to-cell transmission outside the regular conduction system. That's why you get a morphology that is RSR prime. That's where the Ashman beat comes from. Normally, the length of the refractory periods of the conduction system are as follows in descending order. Right bundle branch, followed by left bundle branch, which is approximately the same as atrioventricular node, followed by His bundle. That's the decreasing order of the length of the refractory periods in the conduction system. Therefore, it would be unusual for the bundle of His to be a site of conduction delay in an Ashman beat. The Ashman beat usually has a right bundle branch block morphology. That's all for this episode on localizing the origin of ventricular tachycardias and PVCs, as well as some tidbits on PVCs.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.